Good morning, everyone. My name is Dr. Rashid Ali. Today I am presenting Urology Journal Club. Today our topic for presentation is the management guideline of penile cancer, a contemporary review of Sub-Saharan Africa article, which is published in 2020. So, in this article, we are considering the European Association of Urology guideline and the European Society of Medical Oncology and National Comprehensive Cancer Network (NCCN) guideline on penile cancer. There are also 27 articles were selected for the review based on these contents on current management of penile cancer. Introduction. Penile cancer is a rare malignancy in Europe and America with the incidence of less than 1 in 10,000 men. This frequency is much higher in Africa, Asia, South America, and account for up to 10% of the cancer in some region. The prevalence of penile cancer is high in nations with human papillomavirus infection. The age-adjusted incidence in Brazil is about 8.3 into 10,000 and was even higher in Uganda, commonest tumor in the man in 1916. The incidence in Uganda is declined steadily, probably due to urbanization, better health system, and improving hygiene to a ratio of 3 to 4 in 10,000 men. The incidence of penile cancer peak in 6 decades of life, even though it may occur in younger patients. And middle and low economic countries where circumcision is not routinely practiced, the rate of penile cancer would be 10 times higher. The vast majority of patients in Europe and United States will present with localized disease due to the better health system. Considering in Israel where circumcision is performed exclusively for all men at birth, the incidence rate is low, has 0.1 to 0.3 in 10,000 men. This is unlikely in developed countries due to the poor knowledge of disease, poor access to the health care, and low socio-economic status. Most men with cancer tend to present with locally advanced to advanced disease portending a dismal prognosis. Penile cancer may result in distressing outcome when the diagnosed laterally with 5-year surveillance rate 50%. When pelvic lymph nodes are involved, the surveillance rate may be as low as 0% in 5 years. These are some tables which are taken from this article. The demographic, study period, age, parameter, and occupational and comorbidities are mentioned. The study, Negando et al., Randwa, they presented the study in 2015 to 2016. The total patients selected 30 patients, and the mean age was 60 years, and the age range 33 to 83 years. They are Petri Palmer, and 86.7%. In this patient, comorbidity HIV infected 20%, and HPV not tested in these patients. The second largest study, which is done in Evans et al., South African blacks, which conducted in 2000-2008. The total patients selected 65, and the mean age 50 years, and the range from 37 to 69. And these patients, the occupation not mentioned, and the HIV infected 56%, and HPV 4.5%. And the third largest, Shio et al. In Tanzania, they are conducted 2004 and 2013. Total patient 236, and the mean age 47, and the HIV infected 6.7%, and HPV 5.1% in this group of patients. The second table, we consider risk factor, a clinical presentation of the patient, histology and staging. Negando et al. Did the same study. The risk factor was phimosis 50%, and hygienic 80%, and smoking 56%, and lichen sclerosis 13% of the patient. And the patients which are presented with the subperficial symptom 63%, and penile ulceration 26.7%, and meatal stenosis 10%. and the histology shows 100% they are squamous cell carcinoma. And the stage of presentation, the T1 3.3% and T2 36.7% and 56% on T3 T4 3.3%, and the lymph node and status N0 43%, N1 20%, N2 23%, N3 13%, and M1 just 16%. And the grade and metastasis stage, grade 1 43.3% and grade 2 50% and grade 3 is 6.7%. And the second, Mago et al., they present the risk factor uncircumcised 72.7% and late circumcised 21%. And they are the histopathology 100% squamous cell carcinoma. And the stage of presentation, stage 1 18%, stage 2 is 12%, and stage 3 is 15.9%, and stage 4 is 18%. Their lymph node stages are not mentioned and grade also not mentioned. The third largest study, Wentz et al., they said they just mentioned the histopathology, squamous cell carcinoma 80%, and varicose carcinoma, this is one type of squamous cell carcinoma, which is 15.4%. Then other parameters are not mentioned in this study. And Chen et al., they uncircumcision 89.9%, and smoking 77%, and phimosis 62.3%, and repeated STD 22% of the patient. And the squamous cell carcinoma, the main carcinoma histopathology 99% squamous cell carcinoma. And the stage they are mentioned, stage 1 10, and stage 2 is 11, and stage 3 is 55, and stage 4 is 12%. And the lymph node 65% and metastasis 42%. And this table, management, complication, and follow-up of the patient are mentioned. And Negunda et al., glands penis were involved in 46.7%, and the procedure was done partial penectomy 80% of the patient, and total penectomy 13.3%, and penectomy plus lymph node dissection was done in 33% of the patient. The chemo radiation are mentioned, and complication, surgical site infection in 10%, and lymphocyl 10%, skin infection, death, and meatal stenosis. And follow-up 0% recurrence at 6 months of the follow-up. And et al., their glands are involved in 43.6%, and glands, penis, and shaft 21%, and prepuce 12.7% in this study. And the surgery was the circumcision 3.6%, local excision plus radiation 7.2%, partial penectomy plus radiation 20%, and partial penectomy chemo 5.5%, and partial penectomy chemo radiation all done 10%, and total penectomy radiation 14.5%, and this chemo and radiation along 9.1%, chemo radiation 10% given. So now we will discuss the etiology and risk factor of the penile carcinoma. The human papillomavirus has been identified as the etiological agent associated with penile cancer. HPV isotypes 16 and 18 have been prone to including carcinogen in penile cancer. A study from Thailand, Denmark, Spain show an HPV prevalence ranging from 55 to 65%. Patient with HIV have a 8-fold increased risk of HPV infection. So HPV infection increase the risk of carcinoma increase, thus splitting an associational correlation between HIV and penile cancer. A study by Wentz et al. Elevating black South African male with penile cancer found that patients with HIV infected were most likely develop HPV associated penile cancer at younger age. The association between the lack of circumcision and penile cancer have been well established from several studies. A meta-analysis of 7 case control studies show a strong predictive effect of childhood circumcision against invasive penile cancer. However, this protective effect of early circumcision was eliminated when boys with no history of phimosis were analyzed. Phimosis is a strongly risk factor for invasive penile cancer with accumulation of sigma causing a repeated chronic inflammation and subsequent carcinogen. It can be reduced with dead circumcision, thus eliminating the risk of phimosis that could cause penile cancer. Chronic cigarette smoking, lichen sclerosis, balanitis xerotica obliterans, low socioeconomic state, and education have found as risk factors. Some nations practice childhood circumcision as a routine ritual, thus eliminating an important risk for penile cancer, while others like Kenya and Tanzania have high rate of the uncircumcised men. Low socioeconomic state, education, and poor hygiene remain a unique challenging among most regions in Africa. Results from the study in Uganda showed that there was a higher rate of HPV infection from swab of uncircumcised adult male compared to the swab taken after a year of circumcision. 28 verse 18. How the patient presented. Clinical presentation of the patient. Mainly the penile cancer may present as a visual lesion along the glans, prepuce, or the penile shape. It may be associated with the pain, discharge, bleeding, or mirrors based on the stage of the disease. The disease presentation can be described as a nodular, ulcerative, or fungating. In some cases, penile cancer can be concealed by phimosis. An advanced case of penile cancer constitution symptom may be fatigue, weight loss, and palpable inguinal lymph node could be present. Most men with penile disease in present with advanced stage of penile cancer either due to lack of knowledge, socioeconomic status, or fear of treatment option. Therefore, common clinical presentation reported from Uganda, Guinea, Nigeria, and Cameroon, and Senegal, including penile ulceration, fungating mass, or ulcerative fungating mass. The clinical description denotes a late presentation of the disease. This is a picture which showing the advanced ulcerative and fungative penile mass that is erode the glands, the corporal bodies, and urethra. Pathology of this penile carcinoma. Squamous cell carcinoma is the predominant histopathological type in 90% of the penile cancer. Squamous cell carcinoma of the penis can be further categorized as basaloid, varicose, and papillary. Less common histological variant including adenocarcinoma, melanoma, sarcomatoid, and mixed carcinoma. It is most commonly originated on the glands. The growth pattern could be superficial spreading, nodular, vertical growth, or varicose growth. Race and geographical variation did not affect much the histological type of the penile cancer. As with review displayed, squamous cell carcinoma the most common among the Sub-Saharan Africa males with average of 95.8%. How the diagnosis of the penile cancer? The diagnosis of penile cancer is confirmed by biopsy. Pathological report is essential to draft treatment plan and lymph node management. The excision biopsy is ideal to assess the degree of the invasion and the stage of the disease. Intraoperative fresh frozen section can depict negative surgical margin. The 5 mm of tumor-free margin is considered oncologically adequate. Perform physical examination and document the number of the node, morphology, laterally, if inguinal lymph node or not palpable, upper invasive lymph node staging for high risk patient. Otherwise, imaging, ultrasound, MRI, CT scan may not be helpful to detect in metastases. So, patient with palpable inguinal lymph node may require pelvic abdomen thoracic CT to assess pelvic lymph node and distal metastasis. There is some stage of the TNM staging system is mentioned here, and the TX primary tumor cannot be assessed, and T0 no evidence of primary tumor, TI is carcinoma and C2, and TA non-invasive varicose carcinoma. It's also known as Doppler tumor, because it's most common in tobacco. People they say tobacco. And T1 tumor invades subepithelium connective tissue, and T1 is further divided into T1A when there is a lymphovascular invasion are not present, and T1B when there is a lymphovascular invasion is present. And T2 tumor invade corpora spongiosum or without invasion of the urethra. And T3 tumor invade corpora cavernosum with or without invasion of urethra. And T4 tumor invade other adjacent structure. Also, on the base of the lymph node, NX lymph node cannot be assessed. N0 no palpable visible enlarged inguinal lymph node. N1 palpable mobile unilateral inguinal lymph node. And N2 palpable mobile multifocal or bilateral inguinal lymph node. And N3 fixed inguinal lymph mass or pelvic lymphadenopathy unilateral or bilateral. And M the metastasis state, M0 no metastasis, M1 there is a distal metastasis. So the American Joint Committee and Cancer Tumor Node and TNM system classify is stage penile cancer for prognosis purpose. The stage 0, TIS, TA, N node, M node. Non-invasive varicose carcinoma or cancer in situ is a 90 to 100% 5-year surveillance rate. Similar stage 1, T1A, N0, M0 with no evidence of lymphovascular invasion has a 5-year overall surveillance of between 90 to 100%. And stage 2, T1B, T2, T3, N0, M0, lymphovascular invasion, undifferentiated, poorly differentiated tumor, and within corpora, cavernosum, corpora spongiosum, urethra also have a good prognosis after treatment. And stage 3A, T1 to T3, N1 or M0, single unilateral lymph node is in overall 5-year surveillance rate is 80% constantly. And stage 3B, T1 to T3, N2, M0, multiple unilateral or bilateral inguinal lymph node is in 5 years overall surveillance is 40%. More advanced stage 4, any N3, any M1 and M1, admitting continuous structure N3 fixed inguinal or pelvic lymph node or metastasis disease is a decimal 5-year overall surveillance is 11%. According to AGCC, squamous cell carcinoma of the penis is graded based on the degree of the cell in aplasia. Grade 1 consider well differentiated, grade 2 is moderately differentiated, grade 3 is poorly differentiated, and grade 4 is undifferentiated carcinoma. Recommendation management guideline. If the tumor is TIS or TA, the patient with non-invasive varicose carcinoma or penile carcinoma in situ can benefit from the penile preserving module, including topical 5-fluorouracil or 5 topical enopoamide, circumcision, wide local excision, once procedure, partial penectomy, gnathectomy, as well as laser therapy have shown good result. T1, G1 or G2. Patient penile preserving procedure should be carefully selected in patient regarding the ability for follow-up. Studies have shown that 2-year recurrence rate may approach 50%. Circumcision, wide local excision, Mons procedure, partial or complete gnathectomy, laser therapy or radiotherapy have been indicated in treatment option. The patient should be regularly follow up. A patient is not regularly following a patient very far in large area, the radical procedure may be considered early. Current evidence shows that surgical margin of 5 mm possesses similar oncological safety as 2 cm margin. T1, G3 to G4 or T2 are greater than T2. Partial or total penectomy will be required for these lesions, considering the characters of tumor and depth of the invasion. Intraoperative pressure plasma section can be used to attain negative surgical margin. For selected patient with tumor occupying less than half of the glands, wide local excision or glanectomy are option if the patient can adhere to a strict follow-up plan. The possibility of repeated wide local excision for local recurrence without cavernous invasion or partial or total penectomy for more invasive disease should be discussed with patient. For lesion less than 4 cm, radiotherapy by external beam or brachytherapy are treatment option. The management of invasive disease confined to the corpora spongiosum glands T2 include total gnathectomy with reconstruction of the corporal head. The treatment of the disease involving the corpora cavernosum and urethra T2 to T3, including partial penectomy with reconstruction. Radiotherapy should be considered as an alternative, but will require circumcision first. Patient with locally advanced disease T3 penile cancer should be treated with total penectomy with a perineal ureterostomy should be made before the procedure. More advanced T4 disease should require neoadjuvant chemotherapy followed by surgery when response is observed. Management of the lymph node involvement. Non-palpable lymph node, clinically negative node patient with low risk TIS, TA, T1, G and G1 and intermediate risk T1 and G2 can undergo surveillance. However, patient with non-palpable inguinal lymph node with the intermediate risk and high risk penile cancer, dynamic sentinel lymph node biopsy is recommended. Inguinal lymph node dissection is recommended if a positive node is identified. Unilateral or bilateral palpable inguinal lymph node. For patient with palpable lymph node, a fine needle aspiration is recommended. If results are equivocal, an excision biopsy is indicated to confirm. In the presence of positive lymph node, intermediate inguinal lymph node dissection should be performed. Intermediate inguinal lymph node dissection should be performed if the lymph node are positive. When a greater than 2 node are positive or extranodal disease, a pelvic lymph node dissection is recommended. Adjuvant chemotherapy should be considered. Fixed or ulcerative inguinal lymph node. The risk of metastasis is very high in these patients. Therefore, pelvic abdominal CT is indicated. Multimodal treatment with neoadjuvant chemotherapy with subsequent radical lymph node dissection and these with clinical nodal response. Recurrent regional lymph node. There is no level of evidence for the ideal management of the recurrent nodal disease. However, multimodal treatment including radical lymph node dissection, chemotherapy or radiotherapy are optional. Metastatic penile cancer. Systemic chemotherapy, radiotherapy or chemoradiation should be considered for patients with metastatic disease. The first line systemic chemotherapy regime is cisplatin-based chemotherapy, alpha-smide, cisplatin or 5-fluorouracil or cisplatin. Radiotherapy may be used for palliative, and immunotherapy like pembrolizumab can be used as a second line. Advanced case of penile cancer refractory to systemic chemotherapy tend to rely on supportive care. The main 5-year overall survival for metastatic penile cancer is about 10%. Considering the later presentation of penile cancer, from this review, more multilateral procedures were required comparing to the penile preserving surgeries. Data from the Genoa and Senegal show a high rate of decline from surgery after surgeon suggested penectomy as a treatment plan. The use of chemotherapy or radiotherapy was barely reported except for data from Kenya and Tanzania that use adjuvant chemotherapy or radiotherapy in few patients. Follow-up of the patient. The goal of follow-up and detected early recurrence that could be curable and the management of treatment-related complication. A more intensive follow-up regime is recommended during the first 2 years where recurrence is accepted to be high. A less rigid follow-up plan can routinely up to 5 years. Therefore, which patient can carry out self-examination at home. The follow-up and the review was dismal among men managed for penile cancer in range from 25% to 100% loss of follow-up. Most patients are psychologically and emotionally challenged after penile procedure and may not return to the health institution knowing that their penile length will not be restored. The cost of treatment, distance from the major cancer center and unreported death at home may be contributing factor. Quality of life after penile procedure. Evidence has shown that there is a acceptable sexual activities and quality of life after penile sparing procedure like laser surgery or wide local excision. However, some decline in sexual activities have been observed after gastrectomy and more often partial penectomy. The challenging have been the length of the penile stem may not be suitable for satisfactory sexual intercourse. Some patients have reported to low self-estimate as well as sexual pleasure. A strong family support system should be established before procedure to proceed to penile procedure. The psychological well-being of the patient as well as the partner have a crucial role to play in the follow-up process. Prevention, strategy, and recommendation. Neonatal circumcision is a practice by Jews as seem to mitigate the risk of phimosis, thus reducing the incidence of penile cancer in this population. Some regions are now suggesting routine neonatal circumcision is meant to reduce the risk of penile cancer. The HPV vaccine has been shown to reduce the transmission of HPV infection, thus reducing the risk of cervical cancer in female and precancerous anal lesion in men. It is postulated that the HPV vaccine could provide some protection against penile cancer in men by preventing the transmission of the HPV infection. The conclusion of presentation. Penile cancer rare, with squamous cell carcinoma being the commonest histological type. HPV, lack of circumcision, phimosis, poor hygiene, and low socioeconomic stage are established risk factors. Most men with penile cancer in South Africa present with locally advanced to advanced disease with devastating consequences. The option of penile sparing procedure is reducing with most resulting to multilateral surgeries. The lack of appropriate chemotherapy and radiotherapy worsen the prognosis in this region. HPV vaccination may not be cost effective for most regions in Sub-Saharan Africa. Therefore, neonatal circumcision might be the best advanced alternative for prevention. Thank you.
I think three things come up in this presentation and in this topic of penile cancer. One is yes, it is rare, but it is not uncommon in the sense that during the lifetime of any clinician working in Pakistan, in a tertiary care center, you will see probably one case a year, and that is actually what a tertiary care center should have. Second thing is three things which can be taken as something for prevention. For instance, hygiene, number one. Now, if hygiene is to be observed properly, meaning to say, if you happen to have circumcision, you are actually removing one thing, and that is smegma. And that smegma actually is causing chronic inflammation. So chronic inflammation, either via smegma or without smegma, can lead to this kind of problem. For instance, if you have a patient who has been circumcised, again, that person can have this kind of a disease. So there should always be a suspicion at the back of a mind whenever you examine a patient having a problem like this. Second thing that can be prevented is a strong association of oncogenic viruses which have got with this disease. Now again, with the HPV, human papilloma virus, and its vaccination, it can be prevented. In your conclusion, you have rightly pointed out that it is more so in a region where it is very common, and that is Africa. But it is also it can become common once this viral disease goes unhindered, meaning to say, viruses are not something which are regional. Viruses are something which can change the region, and we are seeing it these days also through pandemic. So humans have always lived with bacteria and viruses, but the problem with viruses is they need a host, and they also mutate very rapidly, and it is sometimes very difficult to recognize them. So you can't just expect this human papilloma virus to be confined to Africa only. Maybe there is a surge in very near future in our region also. So you got to have this kind of theory very clear in your minds as clinicians of future, that this kind of problem, for instance, vaccination for prevention of carcinoma, for many carcinomatous diseases, probably in oncology, probably in urology, is a thing that has to be addressed very soon, very near. Meaning to say, for instance, we have got a vaccine for prostate cancer. Now, this is an area which is rapidly developing. So we must keep our minds open to such topics as vaccination for cancer prevention, since we are dealing and we are discussing cancer. So it is very interesting in a sense that yes, it is rare. It was rare, but maybe it might not be rare in future. And the techniques of reconstruction for penile stump is also very important. You have got a very good tool now, and that is carbon dioxide laser. Now, carbon dioxide laser happens to do not penetrate deeply into the tissue, so it remains superficial. So, if you have got this kind of an instrument, then you can have a very clear-cut margin, and you can shape the stump properly. The other problems, for instance, whenever you see a patient of penile cancer, or maybe you are in the process of diagnosing a penile cancer by taking a biopsy, first you should divert the urine. The best way of diverting the urine is through perineal ureterostomy. So make a perineal ureterostomy because it is something which is continent, it is something which is under the control of sphincter, and the person will be able to empty the bladder properly without soiling the area that has got a questionable pathology. So whenever you see a patient, always make a plan for the patient. You shouldn't be just doing, for instance, a suprapubic cystostomy and asking the patient to have a biopsy and then see what happens. So suprapubic cystostomy is just an interim sort of procedure. Make a procedure which has to be for a very long time so that the person comes out. You can very well close that ureterostomy in future when the person is healthy. Right. So this is a topic that has to be read, and it is a station which is fixed in probably FRCS urology, and there is a fixed station for penile cancer and other rare cancers. So we have to study that topic thoroughly. Its association with lymphovascular spread is also very important, because whenever you are dealing with a cancer of the penile stump, you always try to figure out whether the lymph nodes are palpable or not. But even if they are not palpable, you got to have this inguinal lymph node clearance, and in search of something called sentinel lymph node. So we'll be discussing this important topic of sentinel lymph node in uro-oncology maybe after 1 or 2 weeks, and we'll see what this sentinel lymph node happens to present to us in uro-oncology as it has presented to us as a treatment protocol in breast cancer and other cancers.
Yes. So this malignancy is not very common like other urological malignancies, but really it's important once it happens, and the residents who have crossed 3 years of his training must have seen a case once. And this is also a social issue. So the patient usually here present very late. So the patient may present with the lymph nodes or non-heating ulcer for a longer period of time. So once you see the patient, it must be staged according to the guidelines, and it must be treated accordingly, like organ preserving, like we are dealing with the kidney or other organs. So here should also be the plan for management with organ preserving surgeries. And the surgery is the mainstay of treatment for this, but nowadays there are many centers who are using radiotherapy and chemotherapy also. Any question? Any comment?
Just a comment about organ sparing, because whenever you are in the field of surgical oncology, you should first think about oncological clearance, not organ preservation. Because I have seen a case probably 2 weeks back in oncology clinic where we have done a very good job of partial penectomy, but then the person comes again after probably 1 month with recurrence. So probably the surgical margin and the frozen section was not actually taken, and probably as you have mentioned, it should be like 5 millimeter to 2 centimeter margin which should be negative, that has to be left behind. So if that rule is violated just for the sake of preserving an organ, I mean, this is not something which is on, because again the person is with disease, and you can't expect the person with disease to be with, for instance, satisfaction.
The oncological control is our first intent for any oncological treatment.
Yes, sir. I have a query. Like Dr. Asad rightly pointed out that we should have plan of perineal lithostomy for these patients. But I just had a query that we should do first suprapubic, then wait for the penectomy and see is the urethral margins positive or not. Then make the plan of perineal lithostomy. We should beforehand make the perineal lithostomy, then do the penectomy. And yes, I agree we should have plan of perineal lithostomy, but what's your take for doing the penectomy? Or
It's about the timeline. For instance, if you want to have first biopsy, then CT scan, probably imaging, and then you decide upon doing surgery, and then you are asking the patient to come out of this phase of surgical convalescence. Then how much is the time? It's like 3 months. So the person is we are asking the person to have a suprapubic cystostomy for 3 months. I think if you are planning to have something called adjuvant therapy, and that includes something which is like radiotherapy or something like chemotherapy, then this is a very long call. So if you are calling something on a longer scale, so why you want to have the patient taking care of suprapubic and you asking him to just take care of it, otherwise urine will not be able to come out. So it is better to plan something judiciously as well as with a common sense. I mean, if you want to plan something on a 15-day scale, then suprapubic is advisable. But again, if you are moving on to something in months, then it should be like perineal lithostomy. It's a child's play. For you, at least.
Any other question? Thank you.